So this is what we're going to be going through today. So we're going to kick things off with a case study. We're then going to run through something known as Gestalt psychology. We'll then dive headfirst into the wolves, and if we do have any time at the end, we're going to go through some questions. Now, when we were developing this presentation, thinking about paediatric rashes, how can we make talk about red dots, but then sometimes purple dots, interesting? And so, without help from anyone else, we ultimately decided that the best thing to do would be start the case study. More specifically, one in which I almost messed up. Now, this case came, I've been about 4 years into my practice. I've definitely been starting to develop a bit of an interest in paediatrics. And at this point, midway through a shift, one of the nurses approached me and said, "Hey, is there any chance you could come and have a look at this kid? I don't know what it is, but something just isn't right." So I did what all good nurses do. I put down my Red Bull, came and had a look at the kid. And I did what most people would do. I did general set of vitals, I listened to the lungs, and I had a look at this kid, and ultimately at the end of it, concluded there wasn't anything really wrong with what I'd done. The lungs sounded clear, the vitals were normal. Now the backstory is the mum had brought this child in. He was about 8 years old, and she said for the last few days, had a bit of a fever, had been a bit off, but her main concern was just that he just wasn't being himself. He wasn't an 8-year-old kid. And I agreed with her. And the only other subtle feature that he had was this sort of peeling skin on his chin. Not massive, just a little bit here. And when I took a step back, I got all these normal vitals, I looked at this child and I agreed something wasn't right. It just didn't look quite right. The lights were on, he just wasn't quite home. And so after I did all that, my conclusion was, no idea. And so I got some extra help. I got one of our regs in and got them to have a look at them. They were relatively new to peds, and so I ultimately concluded at the same time, I don't know what it is, I can't quite put my finger on it, but something just isn't right with this child. And eventually we did find someone who knew what they were talking about, and they determined that this child likely had staph scalded skin syndrome. Has anyone come across it? Yeah. And what we were probably looking at was this toxic shock appearance. And it's one of the rashes we're going to talk a little bit about later. Now, what did I kind of conclude from this story? Well, one thing was probably not the best thing for your child to go for his health. The other thing, that's okay. The other thing was that despite none of us having a clue what exactly was going on, we were all able to escalate appropriately that this child was unwell. This child was sick. And so I did a bit of a digging and I came across this thing called Gestalt psychology. So Gestalt psychology is this school of thought that our brains are wired to see things as patterns or as wholes, as opposed to just their individual parts. And so in a clinical sense, what this means is that when you go and see a patient for the first time, that's a paediatric patient, and I think it particularly works well in peds, is that our brains will create first impression, okay? And this can be really, really useful, okay? This was exactly what, for us, told us this child was unwell. We went into our individual parts and did all the things that we were taught, and looked at the vitals and looked at the lungs, and we couldn't find anything, but our brains had given us already what we needed to know, which was, we've seen something, we've smelled something before, our sensory cues are going off, and this child was unwell. And despite not being able to put our finger on it, we should probably be worried. So I did a bit more digging to see just how accurate this Gestalt was, and came across a few studies. So this one looked at senior ED clinicians and their ability to diagnose appendicitis, and ultimately concluded, so this study was about 2019, concluded that clinicians were just as accurate as our current screening tools. Okay. This one here looked again at a very similar thing with sepsis. A little bit of a smaller study published in 2024 at a single site. And once again, they recognised that in the first 15 minutes, senior ED clinicians were just as accurate at diagnosing sepsis or recognising sepsis, either ruling it in or out, as current screening tools. They beat tools such as QSOFA. And another one that was a machine-based learning algorithm, so something AI-driven. Okay. Now this was possibly my favourite of the three. I'll let you read the title. The GCSS, the Gestalt Clinical Severity Score. Now this was a study in which they sat a clinician at the front door and they were required to provide a first impression within the first 2 minutes before any investigations were done of the patient that was coming through the door. And they were instructed to then give them a score between 3 and 15, very much like a score we know about pretty well, right? If you got a score of 15, you were deemed to be quite well, okay? And most likely in our department, probably quite well, right? If you got a score of 3, that would indicate that you were most likely to have quite severe illness. They ruled out any patients, so they didn't make it easy for them. They weren't like, oh, patient's getting CPR. They excluded those patients. They excluded anyone on a ventilator. And ultimately, once again, patients with a score closer to 3 generally had a far greater likelihood of severe illness. They had higher rates of ICU admission, and those with a score closer to 15 were more commonly discharged. Once again, it was quite accurate. Now, what's my takeaway from this? It's not that you should probably go back to your department, recommend to your clinical governance team that you just scrap all the screening tools and position yourself at the front door and say, it's all good, I'm here, I can do it, okay? But it is something that I think when you get that gut feeling and you get that hunch that something's not right, you should listen to it. Whenever I start a shift, particularly in peds, I speak to my staff and I say, if you get that gut feeling that something's not right, but you can't tell me why, please tell me about it. Because this usually means that there's some sort of experience you've had in the past that's indicating that this is similar and last time it didn't go so well, okay? So, before we jump into all the different rashes, okay, and all the distinctive features of those rashes, it's important to think that while the appearance of the rash matters, the appearance of the child matters far more. So sometimes before we dive into looking at exactly what the rash is that the triage note mentions, just simply step back, have a look at the child. Do they look right? If they look sick, they're probably sick, regardless of what the rash ends up being, okay? Having said that, this would be a pretty poor rashes talk if we didn't talk about any rashes. So we are going to dive into the wolves. And as I said, in true ED style, we want to focus on the really bad ones. And so when we're trying to figure out which ones to include, once again, we dive into the peer-reviewed literature, nothing else. And we ultimately concluded that there was about 7 that we wanted to go through today, okay? 7 that we thought were really bad and that we really wanted to cover and make sure that you guys had an idea about, okay? Yeah, we didn't use ChatGPT. And so we're going to call these the Magnificent 7. Okay, now to go through these, we've created a bit of a game. This is our dermatology quiz, emergency edition. The rules are very simple. Number 1, we're going to show you a picture of a rash. You have to either determine whether it was bad or not bad, okay? Rule 2, now admittedly we ran this in resort 2 and most people have a drink in their hand, is a catered event. Rule 2 was that if you got it wrong, you had to take a drink. It's a little bit harder to do that, but we came up with a few solutions, right? So number 1 was maybe create a tally, write it down later, okay, and take those drinks later. Or just simply make it a friendly competition between you kids, okay? So, grab your phones out, scan the Slido, hopefully this one. Put your real name in or an alias. I have a Mr. Bigglesworth, MC Hammer, Hawkeye. There we go, I think we're almost all in. So the way we've structured this, we are going to do a few questions, okay? As I said, you get 20 seconds to determine whether it was bad or not bad, okay? And then we're going to talk about those rashes, and then we've got round 2, okay? So, are we ready? First question. Has everyone got on their phone to answer? Right, sorry, some people weren't able to log in. Temperamental slide base. Okay, I think we've ran out of time. So, this one, we're going to call bad. So this is petechiae or purpura. We're going to be talking about this one a little later. All right, on to... Next question. Alright, 73% saying not bad on that one, 27 saying bad. Mechanical petechiae. So yes, it is petechiae, but we will go through why this one is not so concerning very shortly. And the last question for this round. Alright, I think we're all at votes. 88% bad and 11% saying not bad. 89% saying bad at the end there. This one, HSP, yes. One of the ones we do want to get a little bit concerned about. Okay, we will explain, as I said. So, it is debatable, I know. Okay. Victoria, do you want to take us through the non-blanching ones?
Okay, so the non-blanching ones, petechiae and purpura. Essentially, petechiae and purpura are visible manifestations of red blood cells leaking from small vessels into the surrounding tissue. And that characteristically means that when you put glass up against the skin, they don't blanch. So this can happen for a mixture of reasons, but essentially it comes down to vessel damage. It can be from things like trauma, infection, vasculitis, or problems with platelets and protein. So just to kind of go through the comparison, you've got petechiae, which are under 2 mils, whereas purpura 2 mils are over. You've got petechiae, which are red or purple maculas, which means that they're flat, whereas purpura might be flat or kind of a little bit lumpy. Petechiae are normally quite often benign, and so when they're isolated, they're often benign. So, for example, for mechanical reasons like conflict of vomiting, you can get little burst blood vessels in the superior trochanter region. Purpura, on the other hand, are more likely to reflect an underlying pathology, but that said, not all pathological processes are life-threatening. So, for example, with HSE, quite often it's separate. With these as well, I think it's always worth mentioning that you should also consider non-accidental injury. So what might raise your suspicion? Oh, I'm sorry. Okay, so why do we worry? We worry because of the caveat that little percent, which there's mixed numbers in the literature, but around 5%, so a small percentage will end up being an indication of severe disease. So things like this, so meningococcal disease, sepsis, leukemia, and DIC. And these are the ones that we really don't want to miss. So the thing that might raise your suspicion is if a child comes in with TKI and it's associated with fever, if they look ill or toxic, and then some of these other signs like hypertension, which might indicate shock, neurological symptoms might indicate some CNS involvement, or hepatosplenomegaly, which might indicate arrhythmia. And then some other features are, so location and distribution, if it's widespread, if it's rapidly evolving, you'll be more worried. With SJS and 10, in comparison to the staph scalding, they also, it's very sort of eat, so you have to think about nutrition, as well as like fluid losses and temperature control and stuff like that. And protect against infection with dressings. It's very painful, so analgesia is key, and it's always important to protect the eyes and the mucosa, because again, that, unlike staph scalded, that affects the mucous membranes.
Yeah, so SJS and 10 aren't quite as common necessarily just in paediatrics. It's one of the ones that we look out for in adults as well. But the reason we wanted to add it is because as soon as, so particularly in the case that I had staph scalded skin syndrome, we see that peeling skin. One of the first things that we start to check as well is the mucosa. Because if it's also on the mucosa, we're thinking more SJS and 10. Because whereas staph scalded won't be on the mucosa. There's no desmoglobin 1, and so that's not targeted, therefore on the mucosa, so we don't get any peeling there. Okay. All right, question 9. Oh, phone's died. All right, so we're all chasing Mr. Bigglesworth of rats. Time's almost up. Right, 72% bad, 28% not bad. This one is bad. This is measles, okay? I don't know where our little label down the bottom's gone, but that is measles. Question 10. Okie doke, we had 80% say not bad, 20% say bad. This is measles as well, just in a darker pigmentation. I saw a few people might be playing and like, oh, it's true, false, true, false. You know? Bad, not bad, bad, not bad. A few people didn't vote on that one, so we got 79% that have said not bad, 23% said bad. Urticaria. You would have got it right either way. Okay? Now, as I said, this isn't an exhaustive list. Okay? We determined that there was sort of 7 that we wanted to talk about. Urticaria is a maybe. Okay? I think by itself, it doesn't necessarily indicate severe disease, an allergic reaction. However, if we have that second system involvement, the cardiopulmonary collapse, then we're worried. Okay? So definitely, look, you can either choose to include it in our list, not include it, entirely up to you. Okay? But whatever you answered, you did get it right, so don't worry if you're trying to win. Alright, there you go. So you should be able to vote now. Alright, hand, foot, mouth disease, not bad. Okay, pretty common. Coxsackie causing that one. Oh. You missed it. Too bad. still got 2%. 4% have said not bad. Alright, bit of a gimme. Kawasaki disease, one we're going to be going through, definitely bad. Everyone's asking now, every question now. It's not a potato, I can guarantee it's not a potato. I did have someone asking whether it's human skin. No, it's not human skin. Yeah, it's not that. It was Leonardo da Vinci portrait of me. That's all the hoax ones, don't worry. Alright, and we have one more. Alright, 88% saying not bad on this one. This is scarlet fever. Yeah, Dan, you got it. Okay, you live in the same house, alright? Dan, I think Dan won, but he cheated. Mel was number one there, so congrats to Mel. So that is 15 out of 15 questions, well done. We're going to run through those last few, so the red ones, also known as the erythematous eruptions that we came across. So measles, potentially a rash you may have come across, potentially not, in the developed world, not quite commonly seen. Although, do we have anyone here from northern New South Wales? Yes? Are you guys trying to bring it back? No, I did it. I've got to stay recorded.
One guy who said he was viral emergency accountant because
yeah, with measles. I think we've had a similar case, so I can't really talk on the Gold Coast. We had someone who went around all the theme parks with measles and then came in. So yeah, measles, caused by the measles virus, one we do get worried about for a number of reasons. It is definitely harder to recognise on the darker pigmentation, as we got with that question. And so often, if we're looking at its distinctive features, it's those little red dots that then converge. We call this a confluent rash, okay, or confluence. Okay. Now, as I said, we may not see this quite commonly, and the reason for that is largely thanks to the vaccination. So they originally introduced the first vaccination in 1970, late 1970s, and then the second vaccination introduced in 1992. So children now get this at 12 months of age and 18 months of age, and after the introduction of that second vaccination, rates drastically dropped. So much so that by 2014, the Australian Institute of Health and Wellness determined that we had no endemic cases of measles. Any cases that were recorded were likely introduced. Okay. Looks like a podcast video stock, doesn't it? Now it follows a very specific pattern. Okay. We've got an incubation period, much like any virus. Okay, usually 10 to 14 days. The measles virus enters the body. Okay. Now during this period, we don't typically see a lot of specific symptoms. Maybe children would get a bit lethargic, headachy, but nothing's going to indicate measles. We then hit our prodrome phase, and this is where we get the starter symptoms. We're going to get high fevers. We typically need this if we're going to determine this as measles. And then we're going to get the 3 C's, cough, coryza, and conjunctivitis. Okay. Now it's during this period as well that they start to become contagious. Okay, the 4 days prior to the rash. And so by the time we see the rash, there's already likelihood that there's been spread. Okay. One of the ways that we can get an early diagnosis is by these little spots on the inside of the mucous membranes and inside of the cheek. Okay, these little complex spots, they look like sort of white bluish spots, you describe them as like salt, looks almost like. And these then dissipate when the rash becomes present. But if you see these, you might be able to get that early diagnosis and stop that spread nice and early on. Okay. Then we get our rash, usually lasts about 4 days, and again they're infective and they're contagious during this period. And we get a very typical pattern with the rash. So often it'll start behind the ears, usually start in the face, and then it'll move down into the body. Okay? And as I said, you got those red spots that then converge and cause conflicts. Okay? Alright. Now this is one of the reasons that we get so worried about measles. It's just so contagious. Okay? So in a room of unvaccinated individuals, if the measles virus is in there, 90% will get infected. Okay? It's spread by airborne droplets, okay? And so once a child then left the room with measles, and has then left the room, it suspends there for 2 hours, which is quite difficult. By the time they've walked in and you've isolated them, if you've recognised it early, definitely helpful if you get early recognition, but there's already likelihood that virus is present, okay? The good thing, 95% immunity if you get vaccination, okay, or both vaccinations. All right. Now the reason we get so worried about measles as well is not just because of the virus itself. Yes, it causes problems, but 1 in 3 children are going to get some form of bacterial complication, secondary infection. Okay, and the ones that are particularly vulnerable are under 1. So they'll get a few antibodies from mum, which might get them through to 6 months with some good protection. As they then start to dissipate, hopefully they get to the year 1. They get the vaccination and they'll be boosted. But in that time period, they can be really, really vulnerable to getting measles, and then, as I said, 1 in 3 can get something like otitis media, pneumonia. I think every 1 in 20 children get pneumonia, or in some cases, encephalitis. Okay. Now that full-fledged measles virus as well, as opposed to the attenuated one that you get with the vaccination, can also put you at risk of a later complication called subacute sclerosing encephalitis. Okay, not one we commonly see or hear about, but it is a complication of that full measles virus. It sits dormant and then can become a problem later on, causing permanent brain injury or death. Do you want to take us through a couple slides?
Okay, so the next one, Kawasaki. So it's a vasculitis of the small and medium-sized vessels, in particular the coronary arteries. So it's generally in under 5-year-olds, in males over females. It primarily affects Japanese and Korean descent, and there does seem to be a genetic predisposition. So if a child gets it, their sibling has 10 to 30 times higher risk of getting it, higher chance of getting it. So how to diagnose it? So it's a fever, generally over 39, that's quite often resistant to antipyretics, plus 4 out of 5 of the cardinal signs. So the rash being the maculopapular rash, there's oral involvement with dry, cracked lips and a strawberry tongue. Eye involvement, they quite often get bilateral, non-purulent conjunctivitis. They can get cervical lymphadenopathy, and there can be hand and soles of the feet involvement and desquamation. One other thing is they can actually get arthralgia, so it's something to be aware of for the child. So why do we worry about it? Because essentially, without treatment, it can be self-limiting and resolve within 1 to 2 months. However, around 20% of those that are untreated can develop coronary artery aneurysms, and that figure actually drops to 3 to 5% with early IV immunoglobulin treatment. And these are the 2 mainstays of the treatment, so the IVIG and the hydroxycycline, to kind of calm the immune system, reduce vessel inflammation, and inhibit platelet activation.
Yeah, something I think this one in particular, always suspicious of, is any child that's had that fever for 5 days should be a red flag, and starts looking for those other symptoms. See if it ticks all the boxes. Alright, scarlet fever, this is the last one we're going to go through today. A lot of you got it wrong, and I think that's probably fair because it doesn't look so bad as a picture, but it has this distinctive quality where it feels like a sandpaper rash. And this is again caused by a bacteria that releases exotoxin, it gives us this sort of coarse feeling. And so sometimes it's one of those ones where you'll diagnose almost based on, oh yeah, feel some scarlet fever, get a bit of a history, right. So usually caused by one form of group A strep, or there's a few strains that cause it. Okay, as I said, it releases this exotoxin, and so it usually follows some form of usually a throat infection. Sometimes you can get it from impetigo as well if it's a strep strain. Impetigo typically targets 4 to 8 year olds. So peak incidence among there, and then usually by the age of 10, children have grown out of, well, not grown out of it, they've got better renal clearance again of those exotoxins, or they've developed antibodies, okay? So if we're looking at textbook definition of scarlet fever, it'd be some form of tonsillitis, okay, we can confirm it with the swab if we want, but typically scarlet fever is just subject diagnosis based on history, and then the symptoms. They'll have that sandpaper rash, don't know why it's on his shirt, and a strawberry tongue as well, okay? So much like Kawasaki, you get a strawberry tongue. Management, really simple, antibiotics, okay? Usually a 10-day course of phenoxymethylpenicillin is, I think, the first line, although refer to local guidelines is what I'm going to say here, okay? Erythromycin if you're allergic. Now, when we were creating this presentation, this is Dermnet New Zealand, thank you New Zealand, woo! Dermnetnewzealand.org. Scan that, it's a fantastic resource. You type in your rash, it'll tell you what it is. I mean, look, I know some of you probably just at this point take photos of them and submitting it to chat or Claude. I mean, take your pick. But this is just fantastic. It tells you really briefly sort of what it is, when to worry, what symptoms you're looking for, and comes with photos if you're a visual learner. Love it. How are we going, Tom? Yeah? Alright. Does anyone have any questions? We might wrap up there. We'll be hanging around after, so if you've got any questions, feel free to ask. Okay, so he was all good. Yeah, the 8-year-old. So we got some early recognition, early IV antibiotics. I think we started looking at the mucosal membrane for that sign. You know, is this possibly SJS or 10? Didn't have any mucosal involvement. And yeah, what we were all, I think, looking at was this toxic shock. The cool thing was that having seen it before, I had a child probably about 6 months later that presented, and immediately was like, got staph syndrome. We got him straight in, put him in resus, IV line, and the consultant was really happy. We just sort of stopped that. I got early antibiotics in. So yeah, that's good. Oh, yes.
Have you personally put your slide through Chen or Claude and had a go? I'm not sure that they could have printed you.
No. In terms of like the ones that the Claude or chat.
Generative AI is not great effective yet.
No. I got pretty much all the pictures off Dermnet for most of them, because as I said, you look up and it'll give you the pictures. Yeah, I use it for things like this, and I think the one that I use for the case study, definitely useful. But I love Canva.
I was just talking about the skin rashes.
Oh, the skin rashes? No, yeah, I got them all off Dermnet.
You know, there's a team size.
Oh yeah. Yeah, see if it recognises it. Oh, test it on the quiz maybe, yeah.
Excellent.
Alright, thanks so much.
Let's hear it.
so, we've gone too far. This is a rare event. So in the 0 to 4 age group, it is 6 per 100,000, which is low, but kids don't die very often. So despite being 6 per 100,000, it is about a third of all deaths of kids aged 1 to 14. The most common causes are road vehicle accidents. Other traumatic causes are drownings, assaults, and then some burn structure fires, and then rarely some suicide as well. The death rate has halved for these between 2009 and 2018, particularly road traffic accidents. And the 0 to 4 age group has gone down 68% since 2009, which is all great news. And of kids who do die in transport accidents, 60% were passengers, 30% were pedestrians, and then some others mixed in there as well. This is changing over time. So more passengers are surviving vehicle crashes now, and more pedestrians are dying. And unfortunately, the rate of pedestrian deaths is going up. So it's not just the proportion, but the number of deaths is increasing over time. We're going to talk about why. You can see here, while death from trauma is, while paediatric deaths are uncommon, death from trauma is pretty likely. Unfortunately, from the time you turn 1 to the time you turn 44, your top 3 causes of deaths are dying in car accident. So this is our case. The 9th of December, we're in the run-up to Christmas. It is 5:30 in the afternoon. Our shift on the helicopter finishes at 6:30, so the countdown for us is on to the end of the day. We've had a pretty rough week. Myself, my paramedic, and the crew and pilot have all been on for the whole week. We're on day 5 of 5, we're all pretty exhausted. Unfortunately, we've already been in a pretty sad case this morning of a 16-year-old who broke his neck in the surf and is newly quadriplegic. So we're all a bit emotionally vulnerable at this stage. And we get this call come through from ACC. We've got a 1-year-old who's been run over by a ute in the driveway, who has an abnormal level of consciousness and is not breathing normally. That is all the details we have at this stage. We were tasked early because that has obviously recognised the severity of this incident. So while you all start thinking about how you're going to prepare yourselves to jump on the helicopter and go and see this girl, we're going to do a bit of a detour into some road safety. So we're going to talk about low speed run overs, because that's what was the primary thing in this case. It's pretty uncommon. It's 8 per year, but again, it's becoming more likely. 2/3 of these are from being reversed over, but that's changing over time. In Australia, as of last year, all new vehicles must have reversing cameras. In Japan and the EU, all vehicles since 2022 have had reversing cameras, and in the US and Canada since 2018, all have had reversing cameras. So fewer people are being reversed over. So why are these deaths becoming more common? This is why. So that is the view from the inside and the outside of that view. That is the severity of the blind spots that we're seeing in these new vehicles that are hitting the road at the moment. These are the vehicles that are being marketed as safe family vehicles that you should be driving to school and picking up your kids with. How many of those children do you think are visible from inside that vehicle? Just the last one. Every other child is invisible from inside that vehicle. As a point of comparison, have a look at the design of the hood of that vehicle compared to the SUV in the back. So, what some people are starting to talk about is the vehicular arms race. So, the race to build bigger, stronger, heavier, safer vehicles. Surveys in the US have found that people who drive large vehicles believe that they are safer within a large vehicle. So, they buy large vehicles to feel safer. Those vehicles also come with lane assist, automatic braking, and sensors and reverse cameras. So people feel safe and they feel complacent and they don't feel a need to look at the road because lane assist will keep them in their lane, cruise control will keep them driving, and if they are going to hit something, their automatic brakes will come on. People are buying bigger, heavier vehicles. In 2025, all 10 of the top selling vehicles in Australia were SUVs or utes. All of them were over 1,000 kilos heavier than a standard sedan. Statistics out of the US tell us that for every 500 kilos that a vehicle increases in weight, there's a 70% increase in fatalities resulting from those vehicles crashing. A Toyota Camry, standard sedan, weighs about 1,500 kilos, and a Ford Ranger and a Ford Everest, which are the 2 top selling vehicles in Australia, weigh 1,000 kilos more. So 2.2 times more likely to kill somebody in an accident. For every fatal accident that is avoided by somebody inside one of the vehicles, for every fatal accident avoided by someone inside the vehicles, 4.3 people are killed outside of those vehicles. A US study has showed a correlation between large vehicle sales and pedestrian deaths between 2009. and 2019. Pedestrian deaths have risen by 80% in the US since these last large vehicles have hit the road. Children are 8 times more likely to be killed by an SUV or a truck than a sedan. And cyclist injuries have become notably more severe as well. A hood height of more than 40 inches is 45% more likely to kill a pedestrian. A hood height of the larger vehicle that you can see there is the average height of a 12-year-old. So any child from 12 years or down is taking the full impact of that vehicle across their entire body, rather than pelvis down and rolling onto the road. Driveway collisions in particular, like the one in this case, disproportionately involve these large vehicles with big blind spots. This is an illustration of the blind spots. So the Dodge Ram and the GMC Sierra have the worst. Their blind spots looking forward is more than 2 vehicle lengths ahead of them. If they are stopped at a pedestrian crossing, they can't see the pedestrian crossing, they can't see any child 5 years or younger on the pedestrian crossing. In the top right, you'll see that a M1 Abrams main battle tank has a better forward blind spot than most of the vehicles on that screen. These are the vehicles that are sitting in school zones waiting to pick up kids. And this is the other reason that paediatric traumatic cardiac arrest is becoming more common. I'm from the Gold Coast. I don't know how common it is for everyone else in the room, but I'll see this at least a couple of times a day. 4 kids on a single bike going 40 to 50 kilometres an hour, weaving in and out of traffic, most of the time with no shoes and no helmets. In Queensland, the e-scooter injury admission rate has more than doubled over the last 3 years, and in Victoria there's been a 400% increase in admissions to hospital because of these accidents. Queensland this year has introduced the strictest e-bike laws in Australia, and hopefully everyone else will follow suit. But all e-bikes that are non-compliant are now being considered unregistered motorbikes, and they're being seized and destroyed, and the parents are being fined for allowing their kids to ride them. Hopefully the rest of Australia will follow suit soon. Alright, we'll get back to our case. So, we're planning our mission. We are heading about 50 kilometres north. So, we've definitely decided to fly. It's a pretty dodgy road. It's a single lane all the way north. It's about 50 k's. So we jump in the helicopter, we head north. It's a pretty dense urban area, and so we have to land about 2 kilometres away on a football field. We jump in the back of the police vehicle, they drive us over to the scene. With us, we've got our standard equipment, so we've got about 40 kilos worth of equipment, 2 bags that allow us to intubate a patient and do any of our trauma procedures that we need, 4 units of blood product in an esky, a ventilator, a monitor, and a defibrillator. Further information comes through from the scene. So this comes through while we're in the helicopter on the way to scene. We get a radio call from the paramedic on scene. A single operator ICP has arrived. He's noted the patient is apneic, poorly responsive, and progresses to arrest. So our discussion in the helicopter then is we're going to do a hot drill, which we'll talk about in a moment. We're going to talk about our estimated weight and what drug doses we're going to give to this child. And we're going to talk about how we're going to get this kid back to hospital. And our thought was that in arrest, with needing to do ongoing procedures and needing to give blood and needing to do CPR, we're probably going to need to be in a road vehicle rather than a helicopter. It is extremely difficult to work on somebody in a helicopter, and you need to be strapped into your seat for takeoff and landing, so it's not really an option if you're still doing procedures. So we're going to do a hot drill. Has anyone come across the hot drill before? Cool. This is what we do instead of the H's&T's in traumatic cardiac arrest. It is hypovolemia, so is the patient hemorrhaging out somewhere? It is oxygenation, are they arrested because they lost oxygen? Do they have tension in the thorax? Do they have a tamponade? And then the last T is torn K, which sometimes just gets considered as part of hypovolemia. This is instead of the H's&T's, because if a patient has been in a traumatic accident, they're unlikely to have hypothermia or hypovolemia as the cause of their arrest, so we just throw those out. For patients who have a traumatic cardiac arrest, the ones that do well, patients who have a single stab wound, patients who have had asphyxia, as in hangings, obstructive shock, so pneumothorax, hemothorax in an isolated chest injury, cardiac tamponade if you do a thoracotomy, and electrocution. The ones that do really poorly, isolated head injuries who arrest, always die. There's almost no chance of getting them back. Survival from hypovolemic, hemorrhagic, traumatic cardiac arrest is extremely rare unless they get blood products immediately. So unfortunately, there are some people that just don't do well when they have a traumatic cardiac arrest. The odds of somebody surviving from this point, once they're arrested on scene, is pretty low. And so that was part of our anticipation for heading onto this scene. The workflow for a traumatic cardiac arrest, you want to pull the limbs to length so that the long bones stop bleeding. You want to put a binder on so that your pelvis is bound and tamponaded. You want to start blood products to refill the patient. You want to intubate and ventilate and remove oxygenation as a consideration for your arrest. You want to decompress the chest, and you want to consider a thoracotomy if it's appropriate. With decompressing the chest, any child under the age of 6 can't have a finger thoracostomy. So you do a needle thoracostomy and you consider whether to put in a tail cath on scene, but it's a much harder consideration for anyone below the age of 6. For thoracotomy, we're going to talk about the considerations why you would do it, but it's extremely controversial, particularly in the pre-hospital setting. This is just the Royal Children's Hospital of Melbourne workflow for traumatic cardiac arrest. There's nothing new on this from what we haven't already talked about. The only major difference is that you give TXA at 15 milligrams per kilogram. We haven't talked about that yet, but that's part of the hypervolemia and hemorrhage. So thoracotomy. If you have a penetrating trauma and you have a traumatic cardiac arrest and you've had signs of life within the last 10 minutes, you should consider doing thoracotomy. Conventional wisdom says that you should only do this for somebody who's had a penetrating injury in the cardiac box, but I consider anything between the neck and the abdomen in the cardiac box because it's very easy to get a knife to the heart from that point. In penetrating trauma, we are trying to find a hole in the heart that can be patched, or we're trying to find a hole in a lung where we can do a highlight twist and eliminate that lung as a cause of arrest. In blunt trauma, you need to confirm cardiac tamponade with ultrasound. If there's no cardiac tamponade, there's no reason to do a thoracotomy in blunt trauma. You can cross-clamp an aorta in the pre-hospital setting. They're probably going to be ischemic from the chest down if you cross-clamp their aorta in the field. In penetrating injuries, penetrating trauma, your upper limit of survival is about 1/3 of these patients survive. Probably more likely about 1/4 of these patients survive. In blunt trauma, your upper limit is about 15% chance of survival. Probably more likely about 5% survive. And that is blunt trauma thoracotomy in hospital. So pre-hospital, there was almost no role for this whatsoever. In Australia, we do a clamshell rather than a left chest, particularly in the pre-hospital setting, just because it is much easier to access the heart with a clamshell thoracotomy. So back to our case. We arrive on scene. The patient is in the front of her house. She has been lifted up onto a stretcher so that the team can work on her. The parents are standing with one of the paramedics on the veranda, which was a huge help. They could communicate what was happening to the family. There are lots of people standing outside their house watching what's happening. The police were doing their absolute best with a privacy screen, but unfortunately this was a small community. It was late in the afternoon, everyone was home, everyone wanted to know what was going on. We now have 4 crews on scene, so a heap of paramedics, myself and my CCP, so lots of people to do roles, lots of hands. And as we were walking up, we watched one of the intensive care paramedics intubate this child. So now intubated, ventilated, we don't think oxygenation is going to be a problem, so that's good news. We arrive, she's tubed, she's being ventilated, there was no airway slowing, we're happy with A. We're bagging the symmetrical rise and fall of the chest. The chest doesn't feel deformed, the chest doesn't seem to be moving abnormally, but as part of our workflow, we put in bilateral needle darts to decompress just in case, and then we're happy with our breathing. We have an end tidal of more than 70% at this point and unreportable stats. From a circulation point of view, we are in cardiac arrest. We have a PEA narrow rhythm at about 120. The abdomen is distended, but it's soft and there's some bruising. The pelvis feels stable, the long bones feel fine, but there is some bruising to the upper arms. And we have an unrecordable BDP with a very long capillary refill and no pulse. We cannot see a femoral artery on Doppler or on ultrasound. The pupils are 2 millimeters at this point and unreactive, but not yet blown, and so we do think possibly there's still a chance of survival. We're not looking at a brain dead child at this point. We do an E-fast on scene. There appears to be cardiac standstill. However, the heart is empty. The ventricles are touching. There is absolutely no blood in the heart at all at this point. I can't see any intervention with intraventricular thrombus, but again, I can't see anything in the heart at all. There doesn't appear to be any tamponade, and the abdominal views are poor. I can't see a liver, I can't see a spleen. All I can see is black. And at that point, I didn't know if that was because of the ultrasound, because it's quite difficult trying to ultrasound a 1-year-old without presets in our small screen in the field, or if it was just a positive scan. But we considered it was probably just a grossly positive abdominal fast at this point, with a lack of any other cause of arrest. There was bilateral lung sliding, so we're happy we don't have any virus stress. On paediatric E-fast, so it's less reliable. It's poor sensitivity, it's poor specificity, there's a higher rate of physiological free fluid, there's a higher rate of false negatives. It's very difficult in the pre-hospital setting with a single probe that connects by Bluetooth to your phone, a small screen, and bright overhead environment with a lot of other competing priorities. And in this case, we didn't find any other cause of arrest, and we had a distended abdomen, so we were assuming that we had a positive abdominal fast. Anyway, it probably didn't change our management, and in retrospect, I would have just foregone any fast and started resuscitating to time. So at this stage, we've got endotracheal tube in, we are bagging, our lungs are moving, we've put in our pneumodarts, which didn't change anything. We've got an IO in the left distal femur, right wrist IVC. Now, the paramedic that I was working with, Adam, put in a 22 gauge cannula into this child's wrist who had hemorrhaged to death and had 40 minutes of downtime. It is to this day the most impressive cannula I've ever seen in my life. But that was then our resus line and worked extremely well with wounds. We chucked on a pelvic binder. We used T-pods in the service we were working with. This child was actually too small to have a T-pod placed. The pulley system wasn't working, and so we ended up just having to wrap her up and put some artery forceps on to hold it. We started some extended life plasma, which is our first blood product that we tend to use because that facilitates clotting rather than just filling. We're about 35 minutes on scene. We finished our hot drill and we've had an ongoing arrest. These are our pneumodarts, by the way. They are a 14 gauge cannula, but they are solid metal so they don't kink, and they have this little safety device at the end so that you don't poke a hole in your lungs. So this is where we're at. We've done our hot drill. We didn't need a tourniquet, we didn't need to thoracotomy. We have excluded tension pneumothorax, we've excluded oxygenation, and we've got what is presumed to be a hypovolemic hemorrhagic arrest. We've started some products, got our binder on, and got our limbs to length. We've done everything that Royal Children's Hospital of Melbourne asked us to do in a traumatic cardiac arrest, and we're still arrested. And this was the point we had to make this decision. So we had about 50 minutes of downtime at this stage. We finished our hot drill. We've given 25 mils per kilo of IV blood product, and we were estimating 30 to 40 minutes of transport time in the back of an ambulance. We had an ongoing PDA arrest. We had an end tidal CO2 of greater than 70, and we had what looked like cardiac standstill on focus. I might take 2 minutes and maybe just have a chat to the person next to you about, would you take this child to hospital, or would you call it sick? Alright, hopefully everyone's made the decision. I recognise that it's not an easy one, it certainly wasn't for us on the day. But what we ultimately decided to do was to transport this patient to hospital. The reasons that we did this were probably more social than medical. We thought it's better to have a consensus at the hospital of multiple consultant physicians involved in the decision to cease resuscitative efforts. We also thought that it was probably easier for the family to have this child die in hospital rather than die in the front yard of their house. Our expectation was that we would arrive to hospital and on consensus at hospital would cease resuscitative efforts at that point. At this stage, myself and my paramedic had already decided that this was a futile attempt. We continued resuscitative efforts. We still had about 2.5 units of blood left to give. And the supportive factors medically, even though we did think it was futile, was that the pupils were still small and hadn't blown, and that we had a high end-tidal CO2 rather than a low. And we had PEA rather than asystole. Those were the three things that probably pushed us towards driving. New South Wales Police gave us a green light corridor, so if you haven't experienced this, you get 2 police vehicles. One of them races ahead to the next intersection and stops with their lights on. We fly through, and then the other vehicle follows us and gets to the next intersection ahead, and they just leapfrog back and forth, cutting off those intersections. Despite that, it still took us about 45 minutes to get to Shipman. We had 3 people in the back of this ambulance, an intensive care paramedic, a critical care paramedic, and a doctor, and then we had a patient on the stretcher. We continued trying to give blood, give medications, do CPR, and at size 3, these people kink if you're not holding it the entire time. So we had quite a bit to do in the back of that ambulance. this was the space that we were working with. If you haven't seen the back of an ambulance before, we had the three of us, plus our monitor, plus our blood products, and CPR in progress in the back of this ambulance. This is what it looks like with that many people in the back of the ambulance. And actually, that person you can see standing up at the back of their head touching the roof was between the patient and the paramedic on the left doing CPR. And so it was very intimate and it was very hot and sweaty at the back of that ambulance. In transit, we continued our blood products. By the end of our transit, we had given 65 mils per kilo of blood products. We had given this child an exchange transfusion, in essence. We've given 10 per kilo of TXA, which was a mistake on my part, trying to draw up and dose medications while all this was going on. That should have been 15, probably didn't make a difference in the end, but that was one mistake, just with everything going on. We gave 10 per kilo of calcium chloride, which goes along with our blood products just because of the citrate effect. Calcium is one of your clotting factors in coagulation cascade. I'm sure everyone remembers that very well. We gave intermittent adrenaline en route. It wasn't strictly timed. There was a bit too much going on for that. And we had some intermittent chest compressions going on at the same time. Luckily, our adrenaline actually worked out to about 9 doses over 45 minutes, which is about every 4 minutes, just by luck. And the blood products we were trying to measure out given a fixed ratio, we ended up just running hand on. There are some alterations to advanced life support in traumatic cardiac arrest. So the AMS core guidelines and the Royal Children's Hospital Melbourne guidelines say that the goal of CPR is to simulate normal cardiac function and to circulate blood volume, and these patients don't have blood volume. So the exsanguinated patient derives little benefit from CPR. CPR is virtually never effective in traumatic cardiac arrest, and CPR should not interfere with addressing reversible causes. And that was essentially the approach we took. I was pretty comfortable with us having significant interruptions because there was a lot else for us to be doing. If there was somebody sitting on their hands not doing much, it was appropriate for them to start some compressions at that point, but between the three of us, we had too much to do. But that is backed by evidence. There's been a couple of studies looking at adrenaline, but they're all small studies. There's some case studies. There's not a lot of evidence one way or the other. But AMSCOR say that adrenaline should be given after hemorrhage control, the airways opened, and the commencement of restoration of circulating blood volume, and decompression potentially before ACE. They also say that after you get ROSC, adrenaline is still probably not much benefit because that patient is probably still hypovolemic. And so their answer is give blood, give some more blood, and then give some more blood before you can go do anything else. Now what happened next is that we got ROSC. Very unexpectedly, the IV changed colour, started to move, and started to breathe on her own. She was on a transport ventilator at this point, but we were on a synchronised mode, and so we noticed that she started to trigger some breaths. She appeared very different. We redid our primary survey. We still had our PTT secured. We still had rise and fall of the chest. We actually now got a SATS trace that she was circulating some volume of 99%, which is fantastic. We had good ventilatory volumes on a ventilator. We had a systolic blood pressure of 100 and a heart rate of 120. And we had a capillary refill time of about 4 seconds. And so we then had to radio through and say, actually, this patient's still alive. Can you please be ready to continue resuscitative efforts when we get there? We didn't repeat the EFAST, partly for the reasons I've already mentioned, but also because there was just no chance for us to get that done amongst all the other things that we're doing. I didn't sedate her because she wasn't biting the tube, she wasn't localising. I had ketamine and fentanyl drawn up ready to go just in case, but I thought that the risk of making her hemodynamically unstable again probably outweighed the benefit that we were going to derive from that. These are just the trends over time, and you can see that at the time that we arrived at emergency, heart rate of 120, blood pressure of 110, rest rate of 30, SATs of 99%, and the beds had been moved out. This was an enormous team. There was some hemodynamic stability initially with a grossly positive abdominal fast scan, and the plan was that we should go to CT to find the injury before we went to theatre. However, she unfortunately deteriorated again and re-arrested in ED, which again I think is probably, given the severity of the initial injury, not unexpected. The ED team took the patient up to theatre, continued resuscitative efforts with the trauma surgical team. It was a fairly junior theatre staff. Unfortunately, none of them had any paediatric experience from a nursing point of view. None of them had been involved in a major traumatic cardiac arrest before either. The surgeons opened her up and found an unsalvageable liver injury, and despite abdominal packing and an ongoing TB, they couldn't keep up with the loss. She died in theatre, resuscitative efforts were stopped, and they took the family to PICU after they'd closed her up for some memory making. The family were lucky enough to see her alive and breathing on her own, before she died. And they had to do some memory making in ICU. Sorry. So the things I learned from this case, the challenges in maintaining clinical oversight of a case like this. We don't have a hands-off team leader in pre-hospital medicine. The team leader has to be involved in the resusc of the patient. It is very, very easy to get task-focused on lose oversight of what's happening. What I should have done is delegate a lot of the things that I ended up doing myself, but I just didn't have the bandwidth to be able to do that on scene. Working space and the roles in transit was difficult. Probably we should have done a little bit less CPR, would have allowed us to do a little bit more blood product and some drugs a bit earlier, but that's a hard call when you're in transit. The difficulty of access to paediatric patients. This girl was about 10 kilos, she was only 14 months. It was extremely hard to get hands-on. There was really only enough space for one person at the head and one person on either side of the bed, as opposed to our adult teams where you could get 2, maybe 3 people on either side of the patient. Vascular access was a huge issue. We tried 4 IOs in the end, only one of them worked, and I still think it's a miracle that we got IV access in this patient in the end, because we were really, really struggling. And I think, had we not got that IVC in the wrist, we probably would have been forced to call it on scene because we wouldn't have been able to continue the efforts. The timing to blood products, this is just a reflection of my own practice, could be quicker. I think it's probably the first thing we should have done when we arrived, is just crack the blood products and start resuscitating the blood. It was less than 10 minutes from arrival to blood products going in, but I think it probably could be quicker, and that's just something I'll reflect on for my next time when looking after one of this. Communication with family was the other one. So we were able to talk to them after we went back to the hospital, but on reflection, myself and the CCP I was with actually never really spoke to the family on scene, because we just didn't get a chance to. We were lucky enough that there was a paramedic with the family the entire time, who was able to communicate what was going on and why. But there was a moment that was stick with me, and that is when we made the decision to transport, we started packing up our gear to load into the ambulance, and the mum started screaming because she thought that we were packing up to stop. And so that's just another one for me to just recognise those changes in what we're doing can have very different signals to the families and to us. The take-home points for you. Paediatric traumatic cardiac arrest is extremely rare. There are well-established children's hospital guidelines, but it's becoming more common, and I think you should be prepared for something like this to come across your routine. Know what the hot drill is, know how to execute it, have a bit of a plan for your workflow as to how you're going to achieve it. Remember that your volume resuscitation is critical, and blood product should be one of the first things that you do. Thoracotomy in blood trauma is controversial at best. My advice would be, unless you are very, very confident that they've got a tamponade that you can reverse, don't do it. EFAST is the same. If you've got paediatric traumatic cardiac arrest and you've ruled out all the other causes, just start blood products. The EFAST can come later, but it shouldn't come before you resuscitate the child. CPR and adrenaline don't have a lot of evidence. Do all of your procedures first, and just remember that survival after an event like this is rare, and it's not your fault if these patients don't make it. That's all I have to say from the clinical side of things. There's one last point, which is just my personal little bugbear for this case, and that is the access of the media to these cases. So, the Channel 7 News, as it turns out, have a radio scanner where they're listening to the ambulance calls. They were waiting outside our emergency department to film this. And my opinion is that there is absolutely no need for people to see this. The way they framed this clip is that this was the dad being brought in by police, when actually this was the family being brought in by the only other transport available from the scene. This was a small community, and I actually happened across somebody a few months later who mentioned he'd recently been at the funeral of his mate's daughter. And so I think there is little consideration for how things like this affect the communities that they're broadcasting this to. We do have a privacy screen, but as you can see, it hasn't adequately covered the entrance to the ED, and so I think have a bit of a think about your own departments and think about where journalists tend to set up, and think about whether you can set up privacy screens to protect your families from things like this. That's all I've got. Does anyone have any questions? We did. So we did a big hot debrief with the pre-hospital team. So all of the paramedics who were involved came to the hospital. We did a hot debrief with them outside the room. The ED and theatres and ICU all did their own separate hot debriefs. And then about 2 weeks later, there was a big invite for all parties involved for a cold debrief. This was actually one of the better done debriefs that I had in my time at the retrieval service. Yes, so there are laws coming in about the sensors that need to be on vehicles, but none of them are mandated yet. Most of them are proximity sensors rather than cameras, but I think if these vehicles are going to continue to be sold in Australia, I would absolutely agree that you need cameras on all sides of the vehicle.
Feel better about the heights. I was in the US last Christmas, and I was staying on shortly before, I was staying in Walmart Park, and the top of my hill, and took the top of the wall.
Yeah, this is vehicles sold as stock. This is not including vehicles that then go on to have lift kits installed that then make them even higher off the ground. I'm a motorbike rider, and a lot of the time my head is level with the bonnets of cars around me, so it's definitely a problem.
Okay, thanks for the presentation. Very quickly, but quite is there a reason why you guys use the RCH guidelines?
So we don't. That was more for illustration of the guidelines that are available. I couldn't find any New South Wales guidelines when I was putting the talk together. We have our own internal SOPs for the trauma service, for the retrieval service, but I couldn't find any internal New South Wales documents for the guidelines. But I put this talk together once I've left New South Wales, so there may be intranet guidelines available that I could access. As far as I'm aware, there's no official lobbying to the government from any medical groups at this stage. But I guess that's something that we could write to ASIM about and make our opinions known as ASIM members. But I agree, I think it is a powerful lobbying voice to try and push for these safety features. Certainly the mandated reversing cameras has been as a result of lobbying. So I don't think the government are going to make those rules without external pressure. That was that the college surgeons do lobby for that restraint.
I just want to say thank you.
Alright, I think we'll wrap up there, so let's hear it again.
So thank you very much, Dan, for being so open and sharing your experiences so we can all improve our practices. It really is appreciated. Tomorrow we have 3 presentations again. We've got one on a nurse's perspective in triage in North America, and then 2 sort of wellness-based presentations to sort of finish the week off and get us all set for Friday night, which is the closing party.